So it's worth separating payment from practice. So let's start with payment. Now, there is a large movement throughout the United States, and in fact in parts of the world, to get rid of the fee-for-service payment model. Now, fee-for-service obviously works in a method for cardiologists, but in fact, hospitals and health systems are paid fee-for-service as well, in that if a patient is admitted to the hospital, they're paid. In fact, if a patient is readmitted to the hospital, they're paid. And I have had a number of hospital CEOs say, well, I get paid for readmissions, and the penalties aren't very high from CMS, and I have to keep my hospital full. So I understand that. I wish that were not the case, and there are certainly plenty of hospital CEOs that say, no, I get it. And so the idea of where I believe we are moving is in both hospitals and physicians away from fee-for-service payment and more towards payment for whether it's bundling or capitation away from the fee-for-service world. Now, of course, bundling, which simply in a case like heart failure could mean paying the health system or hospital for the admission plus 90 days after that, that doesn't prevent the initial admission. What it does is it does focus on readmissions. It does focus on the least expensive and best way to take care of a patient after discharge. But it does not focus on, obviously, the first admission because the hospital is paid for that. So I believe we are moving, and I'm very supportive of moving, to systems where the exact payment is not based on how many things you do, but on how well you do it and on reducing the stimulus for people to do more things. So if we get rid of the fee-for-service mechanism, I believe we will be more focused on quality. Now, certainly, the issue of if you capitate somebody, they may get less care. Well, we've seen that 10, 15 years ago. Currently, it is now possible to measure and therefore to incent quality metrics that in the past, 10, 20 years ago, were not really readily available, and they're not perfectly available now. But the idea is to pay in a way that doesn't stimulate either doing too much or too little. And those are coming along. The in-between right now is difficult for all of us. The in-between of between fee-for-service and payment, pure payment for quality, or bundling or capitation. Everybody is trying to walk that fine line. And it's easy to say, do what's right for the patient, but sometimes in the real financial world, that's not possible. I'm hoping that the movement towards doing the right thing for the patient and not doing pure fee-for-service is coming sooner, so everybody will at least understand where they are. Right now, it's a transition period. Now, to different models of care. The model of care we have developed is called Grand Aids. Now, a Grand Aid in the cardiology world has a function to keep a patient healthy, and the first thing they do is deal with patients after discharge from the hospital. So a Grand Aid is a person who in many cases is a certified nurse aide. Now, we can train community health workers to do this. We can even, in some places, train lay people to do this. But the archetype is a certified nurse aide who is then well trained, and after that, after their training, they become someone who goes home the day after discharge and meets the patient and family every day for 5 days. Now, we've found this to be very important. The intensity of that first 5 days is important for 2 reasons. One is the relationship established with the patient and family. And I'll give you data in a minute from the University of Virginia. One of the grandaides at the University of Virginia said, I said, good grief, why is this working as well as it is? And she said, tough love. So the issue here is to send somebody home with the patient who does several things, but does them repeatedly. That's the second point. So the first is the relationship, and the second is repetition and observation. So, day 1, the grandaide goes home. This is not week 1, this is not week 2, this is day 1. And there are several things the grandaide does on day 1. So the first is medication reconciliation. Now, we all know of medication reconciliation as trying to reconcile what happens from when the patient's admitted to when the patient goes home. And those are reconciled. Well, what we do is the grandaide helps the patient and family take everything out of the medicine cabinets, all of the paper bags and all that, put it on the left side of the kitchen table. All the new medicine on the right side of the kitchen table. And then the grandaide steps back and puts that table on video, live video, back with a nurse supervisor. So the key to the grandaide's program is the grandaide is a CNA who's well trained, but they're not making decisions. The person making the decisions is back home and is either an RN or an NP. That person is directing, in this case, the medication reconciliation. That reconciliation then is what was the patient really taking, not what did they show up with in the emergency department. So the idea here of the medication reconciliation is that it's real and it's live and it's run by the supervisor. Okay, the second thing that the grandaide does that day is begin to teach patient and family exactly what to do. Take all those discharge instructions and reinforce those instructions over and over with the patient and family. Medication adherence is at the top of that list. So an understanding of that medication over and over again for 5 days, as well as an understanding with the patient and family what they're not going to take. So it's not just saying, okay, you must take this, but there are medicines that patients just aren't going to take. We had one case several weeks ago where a patient, elderly patient, with a sister who was a caregiver who had just retired from being a registered nurse, told the patient that she shouldn't take the Lasix, that water with lemon in it was much better for her. Well, you don't find any of these things out unless somebody's in the home. So the idea is teaching, listening, medication reconciliation, and then the last thing they do is each grandaide has a questionnaire. And that questionnaire is prepared by their nurse supervisor who's back home. So these questionnaires are stock. We, grandaides, has those for heart failure, for COPD, for AMI, for pneumonia. But they're all changeable. They're written in Microsoft Word. And so the nurse, the supervisor, can change the questionnaire. A lot of these people have 2, 3, 4 diseases. And so those questions are asked by the grandaide, yes, no, filled out on a tablet, an iPad, an Android, and that then goes back to a HIPAA-compliant server, back to the nurse supervisor. We've got a wonderful partnership with Vanderbilt University using their REDCap system, where not only does that make the data available, those data are then downloaded and available for analysis and reporting by Vanderbilt, but then also are available instantly back to be included in part of the medical record. So that questionnaire is answered yes, no. Then the supervisor gets on video live with the patient every day to discuss the answers to those questions. Saves a lot of time to get a bunch of yes, no's, but the supervisor can then ask some of that. In fact, most of the supervisors with heart failure say something like count from 1 to 10, and there's Joanne going 1, 2, need more Lasix. So the supervisor gets to see the patient every day. The family, there's a lot of support that the family feels by being directly in contact with the supervisor. Again, the Grandade is only transmitting that information and reinforcing it from the supervisor back to the patient and family. Now that goes on day 1 and is repeated, not the medication reconciliation, the other 2 are repeated every day for 5 days. And what can happen is, the patient says, this is making me feel bad. And so the medications can be changed in real time where everybody's looking at it and saying, okay, we get it, we're going to change it. Now, depending upon purely the relationship between the nurse practitioner, and the physician, that nurse practitioner can make or not make decisions in the management of the patient. If it's the nurse practitioner, they're a little bit more able to make some decisions than an RN, but that's entirely up to the local institution. So that goes on for 4 or 5 days, and then less. Okay? 2 to 3 days the next week, 1 to 2 days the next week. The idea is by the end of 30 days that the Grandade has empowered, there's a word, the patient and family to begin to take better care of themselves. Grandade's not taking care of these people. Actually, they do vital signs, but they're not doing the typical, what we've come to know about home health, which I'll tell you about in a minute. So the Grandade is there, and the supervisor is the one determining how often the Grandade needs to visit after the first couple of weeks. In most cases, the Grandade extends beyond a month. So the Grandade can see the patient, can call the patient. Many are being seen at least once a month, really for a year. So it is a long-term process to keep patients healthy, and I will now tell you some of the results. So the initial Grandade program was started at the University of Virginia. We have 7 more that are in process of collecting data right now in the US and several overseas. First one was at the University of Virginia, and after 15 months of about 115 patients are the data I'll share with you. Those patients were class 3 and class 4 cardiac, sick people, 4 of them on dialysis. Those patients lived within 60 miles of the university because of the travel time of a Grandade, and they were not home health patients, which is important, and I'll tell you about home health in a minute. So these are not home health patients, 60 miles, sick. Of the patients who were offered Grandades, about 23 to 25% initially said, no thank you. That's important to know. There are people just don't want somebody in their house. Okay, we have apps for that, but for right now, 23 to 25% say no thank you. And that's about twice as good as home health in some cases, but still, we've got to account for the fact that around a quarter of patients, 20, 30%, 20, 25% are going to say no thank you. Of the patients that said yes, and that's about 115, we've had 1 readmission in 15 months that is heart failure related, 1. Now that's down from a base of about 7%. We've had 7 all-cause readmissions, that's about 6%, down from 18%. So a 60% or so reduction in all-cause readmissions. Now that's the data. It's also a 91% medication adherence at a month. So what the Grand-Aids do is create a relationship, whatever it's based on, whether it's wanting to do the right thing for the Grand-Aid or whatever, but they create a relationship and produce results where they're in contact daily for the first week or two, and then are there as much as needed for that patient. So the results are awfully good. That's not to say that there are not other programs that can do similar work, and there are. I come back to the same issue, which is it's going to depend on the patient. Some patients need a degree of support like that with Grand-Aids. It's a lot of support. Some patients don't. We need to determine who does and who doesn't. And that's really in our next phase of work. Now, the Grand-Aids work for the hospital or health system or the physicians. The supervisor works for the hospital, health system, or physicians, not for Grand-Aids. Grand-Aids trains, Grand-Aids helps organize the program, supervises the organization of the program, and then does all the data collection and analysis. But the Grand-Aids belong to the hospital, health system, or physician. Now there's another model that we are working with two very large home health agencies to train their home health aides to become Grand-Aids. Now, that to me is a very interesting model because the home health agencies already have the infrastructure of home health nurses. The home health agencies have supervisors, and we can train them to become Grand-Aids. So there are two kinds of patients now that home health agencies deal with now and in the future. One are the Medicare certified home health patients. Those people are homebound. Those people have issues with activities of daily living, ADLs. And what we're working with these agencies to do is to train their Grand-Aids to do both, to do current home health in addition to do what I said that a Grand-Aid does, with a specific idea of preventing readmission and keeping them healthy, in addition to what the current certified home health does. That's about 20% of patients discharged with heart failure. The other 80%, the home health agency can begin a new business, and that new business is people who are trained to be Grand-Aids and supervisors who provide the kind of support that I was talking about that currently institutions are providing themselves. Now, a rational question is, how is this paid for? And at present, hospitals and health systems that are very concerned with readmissions and Medicare penalties are paying for the Grand-Aids themselves. They own them, they're paying for them themselves. What is starting to happen is it is becoming real clear that the supervisor can bill for a telemedicine visit in many states as long as the supervisor is an NP or a physician assistant. Now, certainly those are in various commercial plans. Medicaid and commercial insurers are fine, but Medicare is not yet paying for telemedicine visits. We hope in the future they do, but one thing we are working on is we have 15 institutions that are working together to produce data ultimately that we plan to present to CMS and petition to get this sort of work paid for. Now, hospitals are interested in not just CMS penalties, hopefully again interested in the right thing to do for the patient, and as I've said, most are. But what Grand-Aids also do is reduce length of stay, which is good for the patient as long as the patient can get sent home to a grandAID and caretaker, the patient may be discharged a day earlier, that sort of thing. So right now, it's mainly cost avoidance. There is some payment through telemedicine, and hopefully a lot more payment through CMS, through Medicare in the future.